Okay, guys, this is going to be a review on Module 7 stuff, so hopefully this will help you study for the final exam. So we are going to go back to Tanya and Betty. So Tanya is admitted for an induction of labor. She is a G4-11111, right? Chronic hypertension at 37 and 4. She's being induced due to intrauterine growth restriction. So do you guys remember some of the causes of intrauterine growth restriction? So hypertension is one of the causes, right? So the provider starts her off with deniprosten and a Cook catheter, okay? 12 hours later, the provider removes the deniprosten and Cook catheter and finds her cervix to be 6, 75%, and -1. So 6 centimeters dilated, 75% effaced, and -1 station. The provider performs an artificial rupture of membranes on her and starts her on oxytocin. So breaks her water, starts on oxytocin. There's Tanya's strip. So a few people mentioned, like, can you go over strips again? So here's our review. So we're looking at this strip. We'd want to figure out a baseline first. And I know that these numbers are hard to see, but this right here, let me turn on my pointer. So I want to figure out a baseline here. So I know it's hard to see, but this is 120, and then this right up here is 150. So it looks like the majority of our line, and this is hard for me to see too, but it looks like the majority of our baseline is 150. Okay, now I don't see any decels. That's awesome. My variability looks like moderate variability. I do have accelerations, right? So I see some accelerations. I don't see any decels. My contractions, I have contractions, 2, 3, so every 3 minutes. Beautiful contractions. I'm great about this strip. I'm really happy about this strip. My oxytocin can continue. So 12 hours later, Tanya's still on oxytocin. Now she looks like her contractions have definitely increased. So going back, let's look at this. So that's every 1 minute. So every 1 to 1.5 minutes. So it's very often, the tachysystole is greater than 5 contractions in 10 minutes, average over 30 minutes. So that's definitely getting close to that. We would continue to monitor at this point in time with just the contractions themselves. The bigger concerns, she's got a temperature of 101.0, uterine tenderness. Maternal heart rate, that's what MHR means, is 120. Fetal heart rate is 180. Ooh, that's not good. So what are we thinking? If you were saying chorioamnionitis, you are correct, right? Or I like triple I, as you guys know, but it's still not in peri. So intraamniotic, intrapartum amniotic infection. Who knows what will be on in class? That's why I like to say. Tanya's diagnosed with chorioamnionitis. Isn't that little baby so cute? Tanya is started on ampicillin and gentamicin. Tanya goes on to deliver a beautiful baby boy, so cute, 7 pounds, 9 ounces, after prolonged rupture of membranes for 18 hours. What? So she was diagnosed with chorio. She had prolonged rupture of membranes for 18 hours. She did deliver a baby vaginally. I don't think I said that, but anyways, it's vaginal delivery. If it was a C-section, she would need another antibiotic added. Remember we said clindamycin is one of them, or metronidazole comes back as being added to where she's on 3 antibiotics instead of just 2. Well, this provider decides to stop the antibiotics right after birth. So sometimes with the vaginal delivery, you'll have 2 different providers doing 2 different things. So you'll have some that do prophylactic treatment where they deliver. They say, well, they basically delivered the infection. I am going to stop the antibiotics. And then you have some providers that say 24 hours after delivery. Your more cautious providers will typically say that. Tyler's vitals at delivery are heart rate 170, respir 68, APGARs are 8 and 9 due to acrocyanosis noted, so we're okay with acrocyanosis. Tyler's allowed to remain skin to skin with mom initially. So, his heart rate's a little bit elevated, but we can sometimes in that transitional period to 170 can be totally normal. Some Some hospitals and some books even say up to 180. So 170, it's like borderline. When you think about these borderline ones, if you're like trying to decide, do I pick central cyanosis or do I pick a heart rate of 6 or a respirators of 62? Well, that's borderline, right? So you just watch, because that central cyanosis, you don't just watch. That's bad, that's bad, that's bad. Okay, so he's allowed to remain skin to skin. Well, the nurse goes back in to assess Tyler. Tyler is noted to have nasal flaring, retractions, and grunting, 3 classic signs of respiratory distress. Vitals are heart rate 180, respirators are 78, so he is tachypnic now. Temperature is 97.1. Remember, babies don't always have the classic signs. I did that intentionally. They're not always going to be febrile. They might have a lower temperature. Tyler's taken to the nursery for labs. What labs would be performed? So of course we want to do blood cultures, right? We want to see if this is a systemic infection. We might also want to do a CBC. That's going to help us look at our white count. And remember, babies are weird. They may not have the same white count that you're expecting to see in an infection because they have a little immature immune system. So you might see those larger amounts of baby white blood cells versus the adult, like the normal white blood cells. So it's like their body's working in overdrive to try to fight this infection. Okay. So that would be kind of one of the things that we look at for sepsis in a neonate. Remember, we also talked, they might look at the CRP, the C-reactive protein, the ESR. But what about an adult? So when we're talking about sepsis, you want to make sure you're not memorizing the neonates as sepsis, right? So in an adult, you're going to see more of that lactate, that elevated lactate, which tells you that the perfusion of the organs is not happening the way it needs to, and they're producing that lactic acid, okay? So that's a really, really important lab to remember when you're looking at sepsis in an adult. So they decide to start antibiotics on Tyler. Tyler's blood culture came back positive for GBS, group B streptococcus. So I know that Tanya was not positive for GBS, but it could always have been missed. So it came back positive for him. Tyler was switched to a narrow spectrum antibiotic once his culture and sensitivity came back. He stayed on antibiotics for 7 to 10 days is usually what we recommend, sometimes up to 14 days. He was discharged on day 10. QP. So Tanya starts to feel significant pelvic pain the day she took Tyler home. Tanya's febrile with a temperature of 102.3 and her lochia has a foul odor. What diagnosis is most likely for Tanya? So if you were thinking endometritis, you would be correct. Tanya returns to the clinic. Oh, back to endometritis. So we would also treat that with antibiotics as well, right? And if we wanted to do a culture and sensitivity, we could do a culture and sensitivity on her lochia before starting the antibiotics. We could do a culture and sensitivity on her urine, just in case it's a urinary tract infection, because that's still possible too. So we would do that before starting our antibiotics. If those culture and sensitivities came back with anything, then we could switch her to a narrow spectrum. So now, 2 months later, Tanya comes back to the clinic. She's just returned to work last week, and she's been struggling pumping at work. So she's been struggling completely emptying her breast. So she probably went from feeding baby 8 to 10 times a day, and now she's only pumping maybe 2 times in a 12-hour shift. Not good. Tanya noticed a hard lump with inflammation on her breast. The area has significant redness. She reports influenza-like symptoms. Her temperature is 103.2, very high, right? What's included in her plan of care? So we're thinking mastitis, right? She's got the very classic signs of mastitis. She's got the influenza-like symptoms, the reddened area. She's got like the soreness on her breast. It's swollen. So yeah, we're thinking definitely mastitis. I was supposed to tell you the plan. Okay, so the plan of care for her, what would that be? So remember, antibiotics are going to be one of the main things that we'd want to do for mastitis. And then we'd also want to give her some anti-inflammatories. That's going to help treat the pain from the mastitis for sure. We would recommend rest because resting up is definitely going to help. So we tell her, definitely take something for the pain, definitely get some rest. We're going to give you some antibiotics, and definitely make sure you're emptying your breasts. So with mastitis, it's key for them to continue breastfeeding, continue pumping. They can't transfer it to baby, but they need to completely empty their breast because that's where the infection is. Okay, moving on to Tyler. Tyler's 18 months old. Tyler is tugging at his ears and seems very fussy. Drainage is noticed as well. Tyler's fever is 101.0. So we've got fever. We've got him tugging on his ears. He's so fussy. He's got some drainage from his ears. So we're thinking otitis media, right? So what do we want to do for otitis media? Antibiotics, ibuprofen, soft diet. So anti-inflammatories for the fever and for the pain. Soft diet would definitely help with the pain, and then antibiotics. So we give them all the normal antibiotics education. Good deal. Now we're back to Betty. I don't know if you remember her. So Betty's son was diagnosed with hydrocephalus, and it was due to a toxoplasmosis infection during pregnancy. I'll tell you, I just read this today. I knew toxoplasmosis was detrimental to babies. I didn't specifically know that toxoplasmosis was connected to hydrocephalus until today, like reading your textbook. I like your textbook and I don't like your textbook. I definitely think that there's some value. I mean, if somebody that's been doing this for, well over a decade can still learn something just by reading a little chapter, or it wasn't even a chapter, it was like a little paragraph, then you can definitely learn some things from it. Again, I believe in the intentional reading though. So if there's any exemplars that you guys don't understand, this is definitely the time to just take a moment, read that section. You're going to take something from it, okay? You will definitely take something from it. Okay, so Betty's son was diagnosed with hydrocephalus due to toxoplasmosis infection during pregnancy. What are interventions to manage increased intracranial pressure? So remember, with intracranial pressure, we want to do positioning. So our positioning is going to be between 15 to 30, right? For a baby, 15 to 30. For an adult, a lot of times you're going to still see 30, but like I said, Saunders does say up to 45 degrees. You want to be careful though, because hip flexion can increase intracranial pressure. You guys remember that. Hip flexion and neck flexion can increase intracranial pressure. So we want to keep the body completely aligned, okay? We want to also maintain their SpO2 above 95%. That's key. Maintain SpO2 above 95%, okay? We also want to make sure that that we're managing their bowels, their elimination. So we might switch to enteral feedings. We want stool softeners if they are eating. We want soft food and stool softeners if they are eating. We don't want them to strain at all. We want a low stim environment. So those are all really, really key things with managing their increased intracranial pressure. Okay. Any stress that can increase it as well. So definitely maintain that low stim environment. So what else are we going to do? Oh, and suctioning. Be very careful with suctioning. So we're not going to just suction prophylactically. We're not going to suction just because. Yes, coughing can increase their intracranial pressure, but suctioning can actually cause coughing. So we want to maintain their airway, but we want to be really cautious with suctioning, okay? So what are some signs of increased ICP? So if we're talking about a baby, bulging fontanelles and dilated scalp veins are signs of an increased intracranial pressure. Bulging fontanelles and dilated scalp veins are signs of increased intracranial pressure, right? What are some other signs for a baby? So, of course, fussiness, high-pitched cry, because they probably have a headache, right? Would definitely be signs of increased intracranial pressure in a baby. The sun setting sign, remember that with the eyes? That would be a later sign of increased intracranial pressure. What about severe increased ICP? So for anybody, having that Cushing's triad, you can see it in babies, but you can definitely see it in adults. So that's where they have the exact opposite of shock. So you have their blood pressure going up, their heart rate going down, right? Blood pressure up, heart rate down, blood pressure up, heart rate down. Respirations are typically going to be bradypnea, but they also might be altered respirations, okay? So those are signs of severe ICP. So what is Jonas at the greatest risk for with a BP shunt placement? Now remember, it's infection. So redness at the surgical site, fever, increased, fussiness, increased signs of increased intracranial pressure would definitely lead us to investigate, make sure it's an infection. And then our normal signs for infection too. If he's older, he is going to have a normal white count jump up. He's going to have that ESR, the CRP. If it's becoming systemic, it might be lactate. So we'll see that with him. What is one of the first signs of increased ICP? Altered level of consciousness, right? Altered level of consciousness is one of the first signs of increased ICP. Okay, guys, that's all. So I hope this was nice and short and helped you be able to study some of this material. I hope it kind of summed it up for you. The only one thing I didn't go over was conjunctivitis. So just remember that chlamydia is one of the main causes for conjunctivitis, right? So chlamydia is one of the main causes for conjunctivitis. And then what else do we want to remember about conjunctivitis? So conjunctivitis, you can have three main types. You can have the bacterial, the viral, and the allergic. Okay, so for kiddos, bacterial is actually one of the most common, and kind of think of like why that might be. Kiddos don't really wash their hands very much, and they love to touch their faces. So that's one of the reasons why bacterial is more common with kiddos. Viral, you might see if they were already sick with something else, and then they get the red eyes. But the difference between that and the bacterial are going to have that gunk. So the chlamydia is one of the main causes from units. Okay, so hopefully, like I said, this sums it up for you, and it was easy for you guys to watch. And good luck on studying. Reach out if you guys need help.